something assistance program. I can get you the acronym for it.
Mr. Chair,
Alderman May.
I have a timing question. So you get a prescription that day and you go Walgreens or wherever you may go and you want to fulfill that prescription. Are they going to charge you $1,000 right there? Or
So
it gets applied before you pick it up?
The member's not going to pay any out of
Okay.
pocket.
I'm just thinking, pay it and have to wait
No,
for a check
no.
back.
They are not going to ask anybody to break out their own credit card. And ServU has identified the individuals that will already be impacted, and letters will go out ahead of time. And if they haven't already signed up for the coupon assistance program, it'll walk through exactly how to do that and how to take advantage of those programs. So you may have an employee today that's paying $100 a month for these drugs, and their cost could go down to $5 or $10. So again, we think it's a win-win. The next change that we are recommending, and the last of the prescription drug changes, actually there's two, sorry, but the next one is exclusive mail order. This is for all maintenance medications. Currently, the city does not have exclusive mail order. How this would work is if I'm taking a maintenance medication, so think of your birth controls, your cholesterol medication, maybe some blood pressure medications, those type of low-cost drugs that you take every day to maintain your health, this would require you to do it through mail order. You will get up to 2 free subscriptions, where if you walk into Walgreens, they'll fill it, but on the third one, that claim will be denied and you'll have to sign up for mail order. It's a really easy process. You can work directly through ServU, and then you'll get your drugs on a 3-month basis, so you'll get a 90-day supply delivered right to your home. My wife has this program through her employer, and it's actually through ServU. Really easy, it's really convenient. There are a lot of savings because 1, the drugs are cheaper, and then 2, we get better rebates for mail order prescriptions. So once people get enrolled in the program, people will tend to actually enjoy it because it's more convenient, and you're not spending all that extra money at Target or Walgreens as you're waiting for them to fill your prescription. So,
Sure.
Alderman May.
I keep interjecting this stuff, but I want to make sure I understand how this works. So I take pantoprazole for acid reflux. So if I'm going on vacation and the shipment hasn't come to me yet, I can call Walgreens or I can call ServU. They'll get the prescription, at least enough of a supply to get me through the vacation. Or if I'm on vacation and I forgot it at home, I can call, fill it nearby.
definitely.
Okay.
Yep, so there's always workarounds in cases like that. I will tell you that they send the next 3-month supply 75 days in, so you should always have at least 2 weeks overlapping. But if something gets mixed up, things happen.
75-day lands and
and you're gone or whatever.
Wouldn't that be nice? That's really
And you do get, like I said, 2 free refills, where if you want to get a 30-day supply at Walgreens or whatever, you certainly can. But there are workarounds in cases like exceptions like that.
Okay. Thank you.
Yep, you're welcome. The last prescription drug change, I'm going to jump all the way to the bottom, is we are recommending changing tiers 2 and tiers 3 from today it's 25 and 35 to 40 and 75. We're recommending this change, 1, because we want to encourage people to try and take a tier 1 medication where possible, and 2, it really gets in line with where the market is today. To have a tier 3 medication only costs $35 is really low. The 15, 40, 75 structure is just much more in line with what we're seeing in the marketplace, and there is some decent savings attached to this plan design change.
These are basically your co-pays as well.
Yep,
On the medication.
on the medications, exactly.
And the mail is listed, that's for 90-day supply, correct?
Yeah, so where it says
Mine's so much
active
higher.
mail, it's
Yeah.
30, 80, and 150. Yeah, it's lower, it's higher because you get 3-month supply.
So if you're on a tier 2 drug and you get a 90-day supply, you're just going to pay that $50 once. You're not going
40.
to pay it.
40.
I'm sorry, I'm looking at the wrong.
Yeah, sorry, it's $40.
But you pay it once. You're not going to pay it every month. You're not
Yeah.
going to pay as if it's a 30.
Correct, and if you want to do it through mail order, you can save $40 every 3 months because you'll pay $80 for a 3-month supply instead of going $40 at Walgreens every single month. So there are some opportunities to save there.
And while we're on that line, RXOOP, that's prescription out of pocket, that's
Correct.
the maximum?
Yes.
Okay.
Yep, and that's not changing, so we left that alone at the 1,500, 3,000, and that's the same as it is today. So the most that anybody would pay for prescriptions is listed there. Any questions so far before I get into the medical changes that we're recommending? Okay, so then jumping back up to just below the exclusive mail order. Currently today, the in-network deductible is 100 and 300. We are recommending a change to 250, 750. We wanted to keep the deductible as low as possible. That is something that the employees have mentioned in previous surveys, that it's a benefit they really enjoy. However, 100, 300 is substantially lower than where the marketplace is. So even changing it to 250, 750 would keep you well below what the rest of the market is, and yet it would supply, significant savings. So we felt that change was necessary. The next change that we're recommending is urgent care copay. So today, your copay when you go to an urgent care depends on what type of doctor you see once you're in an urgent care facility. So if you see a primary care doctor, it's $20, and if you happen to see a specialist who's working in an urgent care room, that copay could be $40. We are changing the urgent care copay to a flat $50. This change is, even though it's not listed as big savings, we're hoping it will change behavior. The big thing with urgent cares, one, we have telemedicine, which is a much cheaper alternative, and we're actually going to be recommending lowering that copay to $0. So that'll be a free service for your employees to use if they have urgent care type needs. They can use telemedicine. So we want to encourage that utilization change. And two, a lot of times people won't set up a relationship with a primary care doctor. They use urgent care facilities for those types of services. And an urgent care visit could be $300, where a primary care doctor visit could be $150. So even though there's not huge savings tied to this change, we're hoping it will change some behavior that'll help control costs throughout the city's health plan.
And Mr. Chair,
Go ahead.
what is the cost to go to your own doctor? What's the copay?
Yeah, the copay is, we are recommending that it goes to $25, so it'll be half the cost of an urgent care visit.
Where is it?
That is,
Or down.
yeah,
And that live health is what you were talking about next.
that is the
where
telemedicine, yeah.
your kid's sick, they got an earache, you can dial in from your phone from home, say, here's what's going on. They fill a prescription for you,
Absolutely,
leave the kid at home and go.
yeah. I have a 1-year-old at home. It's awesome. I mean, he's had croup like 3 times. Instead of taking him to urgent care at 10 o'clock at night, I can just jump on my phone, talk to an actual doctor. They fill a prescription. I go pick up the steroid at Walgreens. It's really convenient, and to have it be free, now all I have to pay for is the prescription drugs. It's a better alternative. Technology is getting pretty impressive what they can diagnose over the phone. And the cost of that visit's $50 to the city as opposed to a $300 urgent care visit. So again, we just want to, when it makes sense, encourage those behavior changes. The emergency room is the next one. Today it's $150 copay. We are changing this copay to $250. One, again, just to get it in line with the marketplace, and two, to drive behavior. The city has some really high emergency room utilization, higher than normal, where people are using the emergency room as an urgent care facility, or again, we talked about it last week, where people are using ambulance services within the city on a frequent basis where it may not be necessary to do so. So we want to, while this is a big change, we want people to only use the emergency room when it's in fact an emergency. If I go to the emergency room and I'm admitted to the hospital, this copay is waived. So it really is only going to, this change is only going to impact someone who may go to the emergency room on a Sunday night with a sore throat and they get discharged right away. If I'm going and I'm having a heart attack or heart attack-like symptoms and I'm admitted to the hospital, this copay is waived and it'll only apply to my deductible and co-insurance.
When you say admitted as an inpatient?
Either admitted as an inpatient, or if they need to hold you to do further tests. I mean, if they determine it's a true emergency, then this copay is waived.
So a person falls, gets
Broken
a
arm,
concussion,
those types of things, yeah.
that fee would be waived.
If I go for a headache though, and they, give me some Tylenol and send me home, I'm gonna pay this copay. The next one, non-emergency use of the emergency room, it goes in line with the prior change, removing coverage for non-emergency use of the emergency room. Again, We want people only to go to the emergency room when necessary, and the city has had a lot of costs applied to this, which is why we're recommending that change.
Mr. Chair?
Alderman Weigel.
Have you looked at, are we saying there's specific individuals that are chronic on this, or it's just kind of spread across our whole,
Both.
both?
I mean, we have certain individuals who have abused it, but it's generally a citywide issue.
Do we have an idea why we're bad for that?
I have several theories. One, I think it was talked about last week. Old plan designs where ambulance rides were free. Your deductible is really low. I finally have a $100 deductible. I can go to the emergency room. I'll be seen right away that night. It may be more convenient. So again, we just want to kind of create some changes that get people to at least think and say, okay, can I use a different avenue of care, or do I need to go to the ER? So.
Yeah, so I'm concerned about that. What happens to the person that does use the emergency room and it's determined by the insurer to be a non-emergency use? Is there any coverage then? They get the entire bill. They have to they have to eat that. What happens?
They would have to eat that.
Appeals process?
There is an appeals process. There's 2 layers. So first,
And who hears that?
what's that?
How is the appeals
The
process?
first appeal is with Anthem, and if they don't like the answer they hear from Anthem, they go to a third-party appeal system.
Is
So
it
there's
like
2
an
arbitration.
arbitrators?
Yep. So there's 2 levels of appeal. If it's ultimately denied, they'd be responsible for that cost.
So, Mr. Chair.
Yep.
I'm gonna present to you an example that happened to my family this summer. My wife and my son went scootering up in the Dells. They were at a campground. Wife fell, blacked out, couldn't remember where she was, scrapes and bruises all over her face. Gets the ride to the hospital. They do all these tests to make sure there's not a brain bleed, broken bones, and everything. In the end, it's determined none of those things occurred, and so now our insurance company's coming telling us you're responsible for $6,800 worth of bills. Now we're appealing that, but to what you were saying, who determines that?
It's ultimately going to be Anthem who adjudicates the claim at the first level, and it's going to depend a lot on how the physician or the hospital codes the claim. Every individual might have a different experience with this, but ultimately those are the 2 parties that are going to make the first determination. It's going to be Anthem and the hospital system in conjunction.
No, assuming, I think we're gonna win our appeal.
Mm-hmm.
My wife's a nurse practitioner and can talk them down, I think, but in that case, I imagine there's a maximum out of pocket that our plan design has. So,
Well, this would remove coverage, so this would fall outside of insurance.
out of completely.
Yeah, that's pretty steep in my mind.
Now, for the example, like with your wife, I mean, when they're running tests and they're that concerned, this is again designed to go after the folks that are going to the emergency room because they have a sore throat, or they have a rash that they're kind of freaked out about. It's those types of things that we're going after. Where you're running several tests and they're concerned about other things. That's not what the intent or what the people that'll be impacted. So.
In this case, and I'm not trying to focus it on this, but I'm using it as an example.
Yep.
The way our insurance is set up, I've got a $4,000 deductible and a $400 about copay or premium share every month. With the way it's worded is, in order to use the emergency room, they'll pay for anything that's at an out-of-network hospital to stabilize the patient.
Mm-hmm.
And so our argument is these were stabilizing things that had to be done. But since they didn't come out positive, I think the insurance company's gonna try arguing they were not stabilizing, they were unnecessary. So would an employee, I guess, how do we have it worded? How is this for out-of-network versus in-network?
So anything that's a true emergency is always treated as in-network. Now, the difference may be.
It's always treated as in-network for an emergency.
Yeah, no matter where you go. Now, the big difference is you could be balance billed. So let me give you an example. If I am in the middle of Alabama hiking or whatever, and I have an accident, and I go to an out-of-network hospital, if Anthem determines that those emergency room charges are exorbitant, they may cap what they're going to pay at the in-network level, and I could be billed the difference. That's what's balance billed calls. So that's one case where it may not be treated as in-network. You could be balance billed. but generally any emergency service anywhere in the country and generally anywhere in the world will be covered. You just could be balance billed. So this, again, is designed for those certain claims, and you can see we had about $80,000 in claims over the last 12 months in this category for those really routine visits that ended up in the ER that don't belong there.
But to your point, how do we define what non-emergency versus?
There will be language in the plan document that will determine that, but it's ultimately up to, like I said, Anthem and the hospital system to make that first determination.
We really need to educate folks about that as well. And Alderman Stefanski's been waiting patiently. Go ahead.
So you said that people have appeals or ways they can appeal things. And you said the first step's Anthem.
Correct.
The people who determine this, are they bean counters or are they actual physical doctors?
They're doctors.
They're generally doctors. It's peer-to-peer appeals.
Okay.
So it's generally a medical doctor. I mean, they do work for Anthem.
Right, but what I'm concerned about is, are these people more concerned about the money dollar or are they more concerned about the patient? That's my issue.
Yeah. I mean, they do their jobs. They take their jobs very seriously. And if Anthem determines something and the patient doesn't agree with it, there is a secondary level of appeal to an outside party. So there's a secondary level.
Who are those people?
They're arbitrators. I mean, they're
Are they medical professionals?
yes.
Okay.
And who pays for that arbiter?
The plan does.
Even if the employee would lose,
Mm-hmm.
the plan would still cover that.
Yep.
Okay. Yeah, thank you. I think we can move on. Yeah,
Okay.
that's a bit of a sticking point. But yeah, please keep going.
Okay. We already talked about the offices at copay. The secondary piece to that is we like to keep it 2 times for specialists to primary care. So a specialist doctor is basically any doctor that ends in ologist. So think of your cardiologist. Yeah, your cardiologist, your neurologist.
Geologist.
Yeah, the rock doctors, that's right.
Geology.
They have extra degrees, so they charge more. So again, there will be people that will be impacted that need to see specialists. Their copay is going from $40 to $50. But what we've found is a lot of times people will build a good rapport with those types of doctors, and they'll use like their cardiologist for everything. So if I'm not feeling well and I think I have the flu or strep throat, I'll go and see my cardiologist because that's who I have a relationship with, where that really belongs with a primary care physician. So that's why we have the difference in the 2 copays. And we'd like to continue that 2-to-1 ratio.
Mr. Chair.
Alderman May.
Copays waived for yearly physicals, things like that?
Yeah, all annual physicals, so age, gender appropriate physicals are covered at 100%, no cost.
So if someone at age 40 or 50, whatever the recommended age is, needs a upper and a lower endoscopy, that would be covered?
That will be covered, yeah, your mammograms, colonoscopies, all of those, routine labs, that's all covered.
Alderman Stefanski.
Okay, so you say an office visit copay is $20, right?
Yes,
That would be
today.
that would be to your primary physician.
Correct,
Now, a specialist has an office as well.
correct.
How can that be different if you get a authorization or a recommendation from your primary physician to go see this person? How can that be determined as a higher cost when it's part of your care coming from your primary physician?
Well, because when you walk into that specialist visit, that visit costs more. So if I go and see a cardiologist, that visit's probably $500 to $700. So as soon as I walk in that doctor's office, the health plan's costs go up. So then the user's health plan, the costs go up.
Okay.
Yeah, Mr. Chair.
Alderman Weigel.
And you don't need a referral to see a specialist.
You can go anywhere you want.
You don't need to go see your primary care physician to get a referral to go see the cardiologist.
Correct.
So if that was kind of old school the way it used to be. But you don't need to go you don't need a referral.
No,
You can just make an appointment with a cardiologist and go in.
absolutely.
I still do.
Okay. The next change I'm going to spend some time on because this is a different change. Today, the way the health plan works is if I go to the hospital, and I have some claim examples that I'll walk through in the coming pages, but if I go to the hospital and I'm in the hospital for a few days, generally once I meet my deductible, everything's going to be covered at 100%, minus maybe some copays that I might have. So really my out-of-pocket cap is going to be capped at the deductible amount. What this change is instead of going from 100% coinsurance, we're moving to 90% coinsurance. So coinsurance is the amount that the insurance company pays after your deductible is met. And we are capping the patient's liability to $1,000 for single and $2,000 for family. So I think this is a good time to skip to the last page, page 4. Because it walks through a visit. So in the coinsurance section on the bottom there, let's say today I have an emergency room visit. Today, all I'm gonna pay is my $150 copay. In 2020, if these plan changes are approved, I will have, that visit costs $1,500. I minus my $250 copay. So I'm left with $1,250. And then I'm gonna pay 10% of the remainder. So here the math is, oh, and I have my deductible. So 1,500 minus my 250 copay. Think of copay as just walking in the door. That's the price you pay just by walking in. Then I hit my deductible. So my deductible, if on a single person next year, will be $250 again if the plan changes are approved. So now I have $1,000 remaining on that bill. Insurance is going to pay 90%. I'm going to be responsible for 10%. I would be responsible for another $100. So that total visit would be $600 to go to the emergency room. Does that make sense how the coinsurance works? You can see even down further, this claim example, this person had a $50,000 hospital bill. Their coinsurance would only be $587 because they've already hit other coinsurance amounts for their other visits throughout the year. So then it would be only $587 for that specific visit, capped at the $1,000. So the total liability would be capped. If you think about it this way, in order for me to hit the coinsurance cap of $1,000, I have to have at least $10,000 in medical bills. So the vast majority of your population will not be impacted, but we certainly do have folks that have more than $10,000 in claims that this will impact. But this is a change, a big change, and it's worth, you know, $220,000 in plan design changes. So this change is made in order to keep the deductible lower. Because I would rather pay my bills 10% at a time. So once I hit my deductible, now I can start to pay, as opposed to if I go to a $500 or $1,000 deductible, I'm gonna pay all the costs up front. So this gets insurance to pay sooner, but it is a big change, so.
Mr. Chair?
Alderman Rowe.
So the a $50,000 visit comes down to $587. Am I reading that right or wrong?
You're reading that right, because if you look at the MRI in the emergency room and the urgent care, we applied $23, $100, and $290 for other coinsurance charges. So you add those three together plus the $587, you get the $1,000 cap. So all four visits in there are accumulating to the cap. If all I had was a $50,000 hospital bill, I would hit my $1,000 cap right away.
Okay.
Yeah, this is basically.
So you're
through time.
combining all these. I
You
got it.
invited
Yes.
once and invited second.
Mm-hmm.
Okay.
Any questions on the coinsurance?
Mr. Chair?
Alderman Weigel.
So this is an example of one urgent care visit. If that was his only event in the plan year.
Yeah, he would have only paid the $23 coinsurance charge.
Right. No, I'm talking about if this was one whole thing, the hospitalization, the MRI, that was all the result of him walking into urgent care.
Oh.
Or the person walking. So next time he goes in, he's already met his deductible.
Yeah, so his deductible's been met, his coinsurance cap's been met. All he or she's gonna be responsible for is any copays that may be associated. So if I walk into another urgent care facility.
So let's say this exact same thing happened again 2 months later within the plan year.
Yeah,
What would they be liable to pay?
$50.
$50 instead of the 2,640.
Yeah, and the 2640 also applies above with the
Oh, that includes
copays.
those, yeah.
So they had some prescription drug copays, some
Oh, okay,
office
that's a total there,
visits.
okay.
That's a
okay,
total.
Okay.
We
Oh, I
wanted,
see.
we wanted to show, like, if someone had a, really significant health claims year, what it would look like.
And notice your two examples are both single,
They're both singles, yes.
can we see this run on a family? What's
Sure.
the difference on a family?
It's gonna be 2 times,
Okay.
2 times the amount.
And Alderman Stefanski, sorry.
So, this example that you showed, and they pay their copay, and they pay their deductible, it's all done. After they hit their deductible, they still have to pay a copay, so that's how that works, you always pay a copay.
You always pay a
Even
copay.
if you've met your deductible?
Correct. And then, so for office visits, we're leaving that as a copay only. So anytime I go to my primary care doctor or I go to a specialist, I'm only gonna pay my copay every time I walk in. Now, the one exception to that might be is if they order labs, some significant testing, that might apply to deductible and co-insurance, but that visit itself was only a copay. Everything else is gonna generally be copay if there is one, and then deductible and co-insurance for those charges.
But now you just said that they could be charged extra for labs and stuff. As long as the copay pay is met, or the deductible, I'm sorry, is met,
Then
they would never have
co-insurance.
to pay for anything other than just the copay.
No, so it goes, think of it in this order, it goes copay, deductible, and then co-insurance. So in example, the first example, if it was all at once, so I walk into the emergency room and I have a $50,000 bill because I'm admitted to the hospital afterwards. In that case, my copay will be waived, but generally that copay would apply, but if I'm admitted, it's waived. And then it goes deductible. Once my deductible is met, then I pay my 10% co-insurance up to that $1,000 cap. So that's generally the order it goes in. So if I only go to urgent care 3 times a year and it's $280 per visit, I'm gonna take the copay first, so $50.
Okay.
Then I have $230 remaining. That first time I go, that whole $230 is gonna apply to my $250 deductible.
Correct,
So now I still have $20 remaining on my deductible.
correct.
The next time I go to urgent care, it's $280 again. I take off that first 50, that's my copay for walking in the door, then 20, so now I'm at 210 remaining. Then I would pay $21 because I'd pay 10% of the remainder bill. Does that make sense? And then if I go to urgent care a third time, I'm only gonna pay my $50 copay.
Okay.
All right, we're making progress.
Yeah, last one. The last one is to create a co-payment for high-tech imaging. This would only apply for CT scans, PET scans, MRIs, and nuclear imaging. So for like your ultrasounds, I have the list of the other ones.
Yeah, just not a plain film X-ray.
Correct. It's your higher cost. So your echo scans, your fluoroscopies, your mammograms, your other radiology, ultrasounds, and x-rays, there would not be a copay. But for the ones that are listed on here, it is a $100 copay. Again, these costs are generally in the $3,000 to $4,000 if I get them done at a local hospital. So we just want, there's that additional cost to that. So those are all of the changes. I'm willing to answer any other questions you may have or concerns you might have about any things we talked about. But those are the recommended changes we are making.
Mr. Chair?
Alderman Weigel.
So at the top of this chart, we have the premiums. You say increase 7% for actives and 11% for retirees.
Yeah.
So if an active was paying, I'll make up a number, $200 a month, they're gonna pay another $14 a month.
Well, it'd be
That's
another
7%.
22, 7%, you're right. Yeah, you're right. Yes.
And the retirees, again, if a retiree is paying $200 a month, they'd be paying another $22 a month. No,
We have the capped rate.
Yes.
Printed
sorry,
out.
surprises.
No, it's okay. I know they're,
No,
they're,
they're still gonna do it, their cap is already hit. I mean, their cap's already figured into their regular rates. So the
365.
increase is pretty much 100% the retirees.
Right, any.
you're saying on the actives, they'd only pay the 7% increase, but the retirees are paying
The full.
100%
Yes.
of the increase. What does this 11% number mean then?
That's how much the rates are changing,
Okay.
or suggesting to be changed?
So right now, retiree might be paying 20% of the total rate, okay? And let's say that's $200 a month. But if the total rate is $1,000, because that's 5 times the 200, theirs is gonna go up $110 a month. So they were paying $200 a month now, and it's gonna go up to $310. So that's like a 50%, that's more than a 50% increase, correct? What the retirees' share is.
Yeah.
Yeah, Mr. Chair.
Alderman May.
This, became aware of this over the weekend, actually, from talking to a couple of retirees, and on the sick, and I had a discussion on this too. Something I don't think we quite fully understood was happening, where I was talking to an individual that retired, said, his first year, it increased by 250, next year about another 250, he's paying $750 more premiums.
There's
But he has another 8 years before he hits the 65 mark. And so as that increases, it's getting unsustainable. And so we've been kind of talking about, should there be some cap on what that premium can be? And so,
Yeah, so
I don't know if anyone has gotten a hold of you at all today.
we
to talk
talked about this briefly this afternoon, and I was made aware of it. So the reason for the difference in the splits in premium is over the last several years, the retirees, specifically under age 65, have had a very large impact on the health plan. In 2018 to 2019, just that population alone was almost $1.2 million in the hole. So for every dollar paid in premium, there was another 1.2 that went out the door that was costs. So their loss ratio was 131%. So again, for every dollar brought in, $1.31 was paid out. That was just in 18-19 alone. In 19-20, so far, their loss ratio over the last 12 months is at 100%. So again, we're barely breaking even on that population. When we ran our budget, Horton's budget, this was as of November 11th, we were calling for a 13.7% increase for the retirees under age 65, and the actives minus 2.5%. So really, the active population, your current employees, have been subsidizing the retirees over the last several years, and the health plan just can't continue to do that. So if we put a cap on what retirees pay, it's eventually going to catch up and bankrupt the health plan. We can't even get a rate cap for your current employees, let alone the folks that don't work here. So Horton, under no circumstances, can recommend capping their liability. It's just that population over the last several years has had a very large negative financial impact to the overall health of the budget, of the health budget.
Alderman Lysak has something.
What is the experience of active employees in that same age bracket?
Like
I'm saying
50
is-
plus.
Yeah.
I would have to
I'm saying
research that.
They cost just as much as the retirees, I'm sure. So we have a high expense for active employees that are in that same age range as retired employees, yet we're penalizing the people that retired, and we're not penalizing the people that are active in that age range.
That may be the case. I know that
Well, it is the case, I'm sure.
the actives as a whole, their loss ratio over the last 12 months is 86%. And in the same time period so 18-19, where the retirees had the $1.2 million hole, the retirees were plus 800,000.
Right, but the
Or the actives.
retirees are an older group. You've got a lot of younger people in the actives that are offsetting the actives that are in the higher age group. What I'm saying is, you're giving the actives in that age group a break that you aren't giving the retirees in that age group. You're penalizing the people for retiring as they're permitted to do by state law at age 55 or whatever, particularly protective services. This is where who gets hurt the most, because they're the ones that had the ability to retire early at age 55 or 53, I think it might be now, where the average public works employee or city hall employee can't retire at that age.
If the city, though, continues or wants to subsidize the retiree population on the backs of the actives, my big concern is then what happens when the budget becomes unsurmountable. You're going to have to you're gonna have to continue to attack the health plan to a point where it'll be hard to attract and retain active employees. I mean,
What do you do with firefighters and police who won't retire at 55 or 56, that are gonna be working till 60, 62 because the health insurance is getting so expensive they can't afford to retire? And we're gonna end up with a bunch of workman's comp claims because we got a bunch of old people out there on the job that probably shouldn't be there anymore.
a lot of.
And that's why the state makes the retirement, early retirement available to protective services.
Understood, and I'm not taking anything away from protective services that want to retire when they're eligible to. However, a lot of specifically firefighters, they have second careers after they retire. Their spouse may still be working, so, I mean, while yes, their cost to stay on the city's health plan may continue to go up at rates that they can't afford, a lot of them have other alternatives to healthcare. I mean, to supply healthcare to a retiree for 10 to 15 years, it's just, their costs are increasing.
It's very high, but to say that their experience rate because they're retired is so much higher than people in the same age group that are active, then maybe we ought to be looking at people in that same age group, by your argument, that are active and charging them the same rate increase that we're charging the retirees. Because they're costing the
Would be
plan more.
subject to
I mean, I
discrimination.
don't see your logic of saying just because you're retired at age 57, you're costing us a lot of money, and the active worker that's still here at 57, that age group isn't costing us. It's costing us just as much.
My logic is less on the age and experience of the individual versus active while they're still providing a service to the city, and those that have provided service in the past and are now retired.
Yeah, but he still provided service in the past.
Understood.
For a lot of years, and now you're gonna tell them, well, if you retire early, your health insurance is not gonna be sustainable to age 65.
And Alderman Stefanski was next.
You're getting, Tom's getting kind of the point across here. You're getting to a point where you're gonna get the retirees' benefits are gonna keep costing more. They're gonna be as bad as Cobra. And this kind of exposes, to me, this kind of exposes the flaws that are in our medical system with medical insurance, medical bills.
No argument
things like
there.
that. So, well, it needs to start somewhere though. Where does it start? Does it start at the insurance claim place where we're spending too much money on buildings like Accurate out on I-94 and their insurance, or Northwestern Mutual or whatever? These buildings that you guys are sitting in, I don't know what Portland's in, but that's an example of where we gotta start attacking this stuff. You can't just keep raising the price on people just because it's part of what you see going on.
Well,
You need to stop somewhere.
The only other alternatives for this budget are to either have a larger increase for everyone, that's gonna be much higher than the 7% for the actives, or we need to go back and provide further plan design changes, because,
Our deductibles.
yeah, higher deductibles, higher copays, I mean,
Well, let me ask you, you stated earlier on the deductible, raising the deductible from 100, 300 to 250, 750 was still well below what is the norm in the area. What is the norm in the area?
I would say the average deductible statewide is probably $2,000 single, $4,000 family.
That's exactly my thoughts. So maybe we ought to be looking at raising the deductibles to be more in line with what everybody else is. I guess the committee last time asked for figures on what was common in other communities in the area. Do you have those figures?
have some,
So I have data from 2017, I don't know what you have, Rebecca.
I
Real
just,
quick, while you're looking, my company is $750 single, $1,500 per family.
Yep. That's
That's
still a
pretty
really
cheap.
nice benefit.
That's still cheap.
That's pretty cheap.
Mine's 4,000, 8,000.
Yeah, most.
And
The 4,000 family.
All
per
5,000, 3 to
paycheck,
5,000.
per paycheck, I pay $114 a paycheck out of my check every month, every 2 weeks.
Mr. Chairman,
Alderman May.
can I quickly? You nailed it right on the head, and I don't blame Horton for this. It's a systemic issue in the United States.
It is.
We've got, I mean, how many people sitting in this room, you don't have to say it out loud, but I would be willing to bet that most of the people sitting in this room couldn't tell you the difference between a premium, a deductible, co-insurance, co-pays, max out-of-pockets, co-pays on RX, all that stuff. The system is extremely too complicated.
Yep.
Now, in terms of our plan design, these are the costs that the city actually incurs. So if we're gonna be down $1 million, when that fund goes to zero, the next plan is we would have to go to a private plan, or we'd be stuck with whatever they give us. So we do have some flexibility in plan design now. I do agree that it would seem wise to have some sort of max cap for the retirees. That just seems like a lot. With all due respect to any firefighters out there, if you got to the age of 64 and you've been working for, at that time, maybe 40 years, hauling equipment and people up and down buildings, fighting fires, that's an extremely high toll on the body. And it has to be a benefit and continue. It has to be affordable in some way to the retirees. And I see what you're saying too, opportunities for other jobs. We talked about, you talked about maybe their spouses have an insurance plan. My question for you is, we kind of talked about this last time, and I know this is a lot in a very short amount of time because there's so many variables. We talked about the idea of paying people to go on a spouse's plan. Was that looked at as a cost savings
Yes.
measure?
Now,
And we can come back to this. I don't want to forget this, but was that something we looked at?
it was, and we have a proposal from Network Health Plan for their family savings plan. They presented us with some savings figures. They're not included in here because it's all estimates. The city, Network Health doesn't know how many people would be eligible for the plan. So when
The numbers aren't tight enough.
they're not tight enough. We wouldn't know until we go through an open enrollment period and we start to see how many people have access to other health insurance and all of those things. So those figures weren't included. I mean, in the way I look at it, any savings we got from implementing that plan would just be more money to help build that reserve back up, and I wouldn't want to count on it because it's more of a gamble what their estimates of how many people they think would switch.
We also talked about preferred providers. So instead of going to the hospital and getting an MRI for $2,500, you go to a specialist that may charge $500 for the MRI. Is any of that built into this?
So when we did the analysis on imaging, specifically like going to a Smart Choice, according to the figures that Anthem provided, they're getting just as good a discount at Aurora than you would be by going to
Okay.
an MRI. And that's the benefit of going to the narrow network that you guys have. The discounts are really steep, which is a good thing. So if we added like a $100 incentive to go to Smart Choice, it would actually be a cost increase as opposed to a cost decrease, which would be the goal of it. So that's why those numbers are not included, because it would actually be a cost.
Mr. Chair?
Alderman Weigel.
On the retiree, the early retirees, which is the big thing there, how many singles are we talking about? How many families? And do we have an idea that if that number's gonna go up or down in the next 10 years? Do we know?
Given the average age of the city, I would expect that number to increase significantly. I think we're on the cusp of a retirement cliff.
There's 210
210
Total?
total,
on.
pre-65.
Retiree.
Right. And that, do you have that broken down by singles or
Yeah,
couples or?
There's 41 family, let's see, 92 couple, and 77 singles. Is that? I did that.
There we go. But we're expecting that to go up even, so the future liability, it's not like, oh, we're over the crest, those numbers are gonna be going down. We're thinking that's gonna go up.
Yes.
And that is
Our
predominantly,
study said 10 years. By 2028, we think we're gonna get over that cliff and perhaps start to go down.
Okay.
But 2028 is the 65 when we start going over?
2028 would be the time in which we'd have less retirees on our plan than, or I shouldn't say less retirees on our plan, because we have many more retirees than actives. But the time in which we start coming back to even as far as our OPEB liability costs, which are retiree insurance
yes,
costs.
and it's that 55 to 65 group. That's
Or
the-
perhaps 50 to 65.
50, oh yeah, 50 to 65. What's our earliest retirement age?
50.
50. And these are predominantly
All
police and fire?
protective. Protective is 50 is a reduction on retirement, 53 full. Regular general, 55 reduction, 65 full.
That's, so police and fire is what's,
Correct.
we're thinking 90% of these are that, unknown?
Mr. Chair, in 2019, the premium rates that they paid monthly were between $0 and $888. The ones probably in excess of 600, 550, maybe 600, those are the family plans.
So having a retiree in a family plan is not common, other than
No.
police and fire
Police and fire, yeah.
usually.
So, Mr. Chair,
Yep, go ahead.
hypothetically, let's say we said the premium share that a retiree would pay would be no more than a part-time employee. So hypothetically speaking here, what would the cost implication be?
Nothing,
Because they're all already below that?
correct.
And I'm just throwing that out there as an example. I'm not saying it's something we should do, but, you know,
Yeah, it's like 400, 800, and 1,200 or something.
what's it, 400?
Those are just very round numbers. It's probably a little bit more than like 424 or something.
So the exposure right now for family, 1,200 for
Yeah.
part-time, is what, so a part-time
100
employee,
1,100, say.
so an employee right now with a family, premium cost per month, right now, is $1,100.
That would be under your scenario, the cap. I think Rebecca just said 880 was the highest one, and there's not a lot at that level.
I think
the
there was 5 or
average-
6 of
Yeah.
them, and they're all family.
It's still a lot of money.
And we don't know how many of those would have a spouse with an eligible plan or have access to another plan through potentially another job.
I don't know.
We don't know.
There's also the federal marketplace, the exchanges, where if they are truly retired and they're not working and they don't have any income, the exchanges could be a place where they could receive very good health plans for very little money, if they truly are retired and don't have any income coming in. So,
Because they get a subsidy on the exchange at that
Correct.
point, what you're talking about.
correct.
One of the other things we talked about is the possibility of if they do have another job themselves that provides health insurance, that family savings plan could also
Pay
apply
them
to
go take
them.
that.
Correct.
It doesn't have to necessarily be a spouse.
Yeah.
Alderman Stefanski.
You said they can go on a federal plan, and you said as long as they're not making any money, but isn't their retirement and stuff like that part of their income?
If they're,
WRS.
yeah, getting a pension or WS, that will offset it, but,
So they would still be getting income and they couldn't go on this federal plan,
but
correct?
that, I mean, I don't know what a WRS pension pays, but. It's
good.
Because it's like 5 years of your salary or average.
top 3.
Top 3.
Top 3.
So, yeah, that could offset it, yeah.
Okay.
So they would still have availability, just not subsidy.
Yeah.
There's still a federal marketplace even without subsidy.
Yeah, and I think
Like,
that
Probably, like it is.
and what we're offering at $800, $1,000 a month would be a better plan than what you can get on the marketplace.
Exactly.
Probably.
Did you want to talk about the deductible?
Whole healthcare market in general.
Sure.
Do we want to
It's just nuts.
go back to the deductibles at all?
We did a survey, this is back to, I believe, November of 17, so it's a little dated, but we went to City of South Milwaukee, and I can send this out if you don't want to scribble it all down, or Rebecca has it too. City of South Milwaukee, City of New Berlin, City of Sheboygan, City of La Crosse, City of Janesville, City of Oshkosh, Brookfield, Menominee Falls, Cudahy, Waukesha County, and City of Racine. Then there were 5 of those 12 that had a single deductible under $500. There was 1 between 500 and 1,000, 3 above 1,000, and 2 above 2,000. Now this is 2 years old. The odds of any of those plans getting richer is almost 0. The odds of those going up are substantial. I'll give you an example. The City of Racine 2 years ago had a single deductible between 500 and 1,000. They just moved to a 3,000, 6,000 high deductible health plan, HSA compatible plan. I know that because they're a client of ours. So at best, these groups stayed put. At worst, those deductibles probably have gone up over the years. So that's just a list of the comparables as of a few years ago.
Mr. Chair,
Yes.
I have a little additional information. I think I mentioned last time, the state, their lowest cost has a deductible of $250 and $500. A lot of smaller municipalities might use them as their health insurance. They get the health insurance through the state instead of having their own plans.
It is an option.
For our experience, it would be incredibly expensive.
More
but-
expensive than what we're.
Yes, just because of our claims experience. So I'm just pointing out that a lot of our competitors, per se, might have the state plan at $250 and $500. City of Milwaukee is $750 and $1,500. Milwaukee County, $1,250, $2,500. North Shore Fire, they have a co-pay plan, $1,500 and $3,000. Kenosha, high deductible health plan, $2,500, $5,000. The city of Waukesha has a lower, $400 and $800. So those are
So
some
what we're
things to,
proposing is better, richer than all of those that you're identifying,
except for the state.
except for the state.
And even the state is a narrow network HMO. So in this area, it's going to be Aurora or Ascension narrow network.
Yeah.
With an HMO where you have to go see your primary care doctor and then you have to get a referral to see someone else. So while it's a good plan design, it's certainly different.
Mr. Chair?
Alderman Weigel.
You're saying that our bad experience rate is based a lot on how generous our plan has always been with low deductibles and low copays. So people didn't have to feel the pain as much.
I think there's
Am I characterizing that correctly?
I think
or-
there's a component to that. I think because of the plan design, there has been it's maybe not the perfect word, but some abuse. And again, I don't like that word, so if I think of a different one, I'll use a different one. But you know, if I only have $100 deductible as a single person on the city plan, it doesn't take much to get to $100 in today's healthcare market. Now, if I need something, I'm going to try and get it in at the end of the year, or I'm going to keep going, or I might go to the emergency room on a Sunday because I just want to go and get my prescription or whatever. We were hoping that the changes that we're recommending will create some consumerism and some thought around where I'm seeking care, which will hopefully save everybody dollars, including the employees and the retirees. That's the goal.
So consumerism.
Consumerism, correct.
I love that word.
Yeah.
Because you can call your doctor and their office and ask them how much this visit might cost.
But they won't be able to tell
They
you.
won't
No
tell
one
you.
has an idea.
No.
Not even the doctors.
No. How much for this procedure? Nope, no idea. You have to do it, we'll see what it comes out at. Even
Agreed.
for something as standard as 3 kids for physicals and, you know,
Should be included.
And my experience is what you're talking about also. My doc knows I'm on the Cadillac City of West Allis plan, and he's always happy to send me for all kinds of tests and all kinds of treatment that would that happen if I had another health plan. I think maybe not to that extent. It's part of healthcare. Yes.
Talking about this mix of all these things. So the idea of a copay, of co-insurance is, once you get past the deductible, you still have to pay a portion when you go to the doctor. So it might drive behavior that, see, the thing is, we want people to go to the doctor if they're really sick.
Correct.
We don't want them getting to a point where it becomes a workman's comp claim or it becomes something like that. But at the same time, that co-insurance helps break up costs. So you're not paying a big chunk of change right off the bat. Is there any plan out there that has a $0 deductible with higher co-insurance?
I haven't seen one. The only difference is I've seen plans that won't have a deductible. They just have higher copays, and it kind of does get to consumerism because now my cost is just going to be the copay. So like Kenosha County did that for a while. Now they've introduced deductibles over the years, but back in the day they had just a copay plan. So if I had to go inpatient hospital, I'd pay a $300 copay per day to a max of 3 days. If I went to my doctor, it's $20. So there was a set charge for every service. I've seen that. I have not seen a $0 deductible with higher
This is
co-insurance.
just exploring for the sake of exploring the issue.
Yeah.
I'm not saying this is something we should do, but if the whole idea is to drive a behavior within the people who use the insurance such that they get the care when they need the care, but they're not doing things for, because they can. It would seem that co-insurance does a better job of driving that type of behavior than a deductible.
Well, co-insurance will make you pay a higher dollar amount quicker. If it's,
30% co-insurance
Yeah,
is
you're-
higher than 10%. Yeah, that would be triple what the 10% is.
right.
I
Well,
like the
what I'm saying- I'm
the
saying the first
telemedicine
time-
thing.
The first time you go to the doctor for that $50,000, January 2nd, you have a big fall, $50,000 bill. We've got it now, you're gonna pay that $250 deductible, and then you're gonna pay the $1,000 on the co-insurance.
Yep.
Whereas if you went straight co-insurance, I see what you're saying.
Yeah.
Yeah,
You're-
because if you did 30%, that cap of $1,000 probably going to go up. So there's a lot of health plans that have a 10% coinsurance to a max of $8,000, $10,000. The limit on the ACA is $16,000 now. So there are a lot of plans that people can be impacted for those large claims at a much greater difference than what we're proposing here. So
Explore another idea. You drop the premium share, but then you increase copays and things like that.
it's to use an old expression, you're just robbing Peter to pay Paul. It's just cost shifting. So anything you do with
Putting the cost more on the people who actually use it.
that's the plan changes. The premium is for everybody. So if we lower the premium and then we can certainly shift the dollars. Really what we're trying to get to is a dollar amount that makes sense for this healthcare
make the
budget
plan
to make the plan
For our
financially
constituency.
responsible. Yes.
Our customer.
for the
Our
cities,
customers being are the people on
Our
the plan.
employees and
employees,
retirees.
and their dependents.
And our future employees and our future retirees.
Yes.
How long do you, if we make these changes, I mean, obviously we'll review it every year.
Mm-hmm.
And how long before you think we're gonna see the behavior changes that we're trying to drive? I mean, some people will pick up on it right away, I imagine.
Yeah, and there's-
Some people will never change.
Yep.
Do we know, I mean,
And we can't make people change.
No,
It's
we
ultimate-
can't.
we can just incentivize them to do so, and there'll be a lot of education coming between now and March 1st, between open enrollment meetings and educations. We're looking at that Health Joy app that I talked about last week. So there will be a lot of education forthcoming to help people be best utilizers of the plan. But if I want to go to the ER, I certainly have that choice.
you can go, because it's gonna cost you more.
Correct.
If you have a sore throat on a Sunday night, you can go to the ER, or you could call a teledoc or whatever we're calling it.
For free.
For free.
Correct.
Telemedicine.
Alderman Stefanski.
Have we brought this plan or these options to the people who would use the insurance?
There was a committee that's put together that had input and Alderman May and Alderman Chapleski are on that. Did I get that name
The
right?
employees
Okay.
here in the city, it hasn't been brought as a whole to them yet,
As a whole,
to
no.
give them the options and say, hey, these are what we've got, this is what we could do, this is what we recommend type of thing.
To the whole employee base, no. There's a committee that I think is pretty well represented. I don't know.
Who else was on that committee? Department heads?
Couple department heads, and then three department heads, and
We did have a survey that we did in 2018, I'm trying to find it, where we collected data on people's preferences regarding increased premium shares, deductibles, or things like that, I think.
But I think to Alderman May's point, to a lot of people, this is just crazy.
They wanna know their cost.
It's what?
Too
Out of
confusing.
their
Oh, yeah.
paycheck every 2 weeks or whatever.
Yep.
They wanna know what they're gonna have to pay when they go to the doctor. That's the thing that's the thing, if I think we take this to the employees and spell it out in layman's terms instead of the insurance jargon terms, I think it would be more beneficial to get
Complicated
them,
systems need jargon.
to get people to understand what's going on and
They don't.
be able to make a better decision on their healthcare.
Well, any changes we've made, and this is both for the retiree population and the active population, we've done in-person meetings, we've set up, our contact information is everywhere. If people have questions, they're free to contact us. We try and make it as simple as possible. Unfortunately, we do have to use some insurance jargon, because that's what they're gonna get told when they're at the doctor's office, so we try and use the terms that they're gonna be aware. I mean, we try and do our best to educate
It is all
employees
English.
and make ourselves available to them, so. And we're gonna do that again this year, no matter what final plan design is agreed upon, so.
I just find that where I work, that works out best. They pull everybody in and
Yeah.
say, 3 weeks worth of meetings, and everybody's a mandatory meeting that they have to attend one of them.
Mm-hmm.
They get it explained to them, they get to give their input,
We do this.
and then
And the city
they
has,
come back
We
and
do
they
that.
make a
and the city
decision.
has done that in the
We do
past.
that.
Okay.
It's not mandatory for retirees.
No, but I'm saying active employees,
Yeah.
because,
Mhm.
how many, you're not gonna maybe get the retirees coming in, but you can pass.
You
it
can't
on.
make them come. Yeah.
Mr. Chair,
Alderman May.
we talked about changing the stopgap, the stop loss.
Mm-hmm,
Right now it's 175,000.
correct.
And there's gotta be some sweet spot where we lower the stopgap where
Mm-hmm.
it would save some money. Do we have any ideas what that amount is? I mean,
Not at this time. We're expecting our stop loss renewal probably within the next 30 days, definitely within the next 30 days. So once we get that number, we'll begin to negotiate with Anthem on that increase, and we'll look at other values. I'll tell you, if we go from 175 to 150 or 125, there's gonna be some give and take there, because if we lower our liability, our fixed costs are gonna go up. Or, in the past, you've increased your liability all the way up to 275, because then your fixed costs drop way down, but then you take on more risk. So, it's our firm's job to make sure we're in that sweet spot, and we'll do that analysis and present that to you.
Mr. Chair, and I
Ms. Groh.
think in the last year haven't most of the claims been
Yeah,
smaller?
we've only
So we'd
had-
have to lower.
they went
we're-
down.
Yeah,
I
they're
thought- how many
smaller, a
claims
lot
do we have over
more
100,000?
smaller ones. Like
Not
13 or.
individual claims, but how many participants over 100,000?
16.
And before that.
The 11th.
The death by 1,000 paper cuts.
Oh, yeah, here we go. As of November 11th, with data through September, we have had total paper, 1, 2, 3, 4, 6 with more than $100,000 in claims.
Totaling approximately,
I'm gonna call it $1 million roughly.
And only 3 of them.
Only 3 of them have hit the stop loss. So we are going to receive, we haven't seen all these dollars realized yet, but through this plan year, $270,000 in specific reimbursements.
Coming back.
how much is our existing stop loss per employee or per participant in the plan? Do you know?
Well, this is under 65. Let's-
We said death by 100 paper cuts.
Yes, I got one
So
already.
actives and retirees, we pay,
I didn't go to the emergency
You
room.
can just phone it in now.
our total stop loss fees per month are $84,000 per month, so you times that by 12. Gets you a number. Our total fixed costs, when you include admin, prescription drug administration, other fixed costs, some taxes and stuff, is $1.6 million annually.
That we're paying in stop loss.
Stop loss, admin fees, some taxes.
So quite a bit per employee, per participant. basically.
Yeah, our stop loss fee is $122 per employee per month.
Per month.
Mhm.
It's very expensive, and when we went from the 275 to 175, that was the place where it was what you would call a
The
sweet spot.
The sweet spot to break.
All right, well, we've had quite a discussion here. I don't know, I don't think we're ready to vote on this. Our plan isn't to vote on this now. So I appreciate you coming, as always, and taking some hard-hitting questions, too.
It's all right.
So thank you for that. Alderman May.
Do we have a way to get that employees and retirees can, we have a system where they can log their complaints or something? I mean, I open up my phone line if anyone wants to call. I'm happy to talk to anybody, but I'd be curious to get people's opinions on it as well. The
Ask Allis,
co-insurance
ask Allis.
versus the deductibles versus all this other stuff.
What is the bottom line goal?
Well,
Certainly, we
it's- the
can do
bottom
that.
line
We did that
goal is we
3
gotta
years
find
ago.
We gotta find $1 million
Yeah.
to keep the fund solvent, or not solvent, but keep it going at its current.
Most of the feedback that I usually get is, I just want it to stay the same, and I don't want to pay more.
Well,
But we
it's gonna
certainly,
change.
Everybody wants that.
That's
yes.
not an option, but.
Yeah.
So we can certainly bring in and
Well, look, people
open
have
it up.
ideas, I'd like to hear them, I guess is what I'm saying, and this isn't really we don't really have a system wherein people can come and,
Yeah, we've tried
like
having.
a town hall?
We've tried having town halls where people to come about budget ideas and things like that. They're not.
And no
I've
one
tried,
comes.
right? I've tried to go to, yeah. So certainly we can set up an email address, or they can come talk to me if they want to. If they have ideas.
I'd like to hear from employees what they're
Just
thinking.
send out a quick survey to employees. They have emails, right?
Mm-hmm.
You send out just a short survey. Health insurance costs are going up. The council is looking at making changes. We know that you don't want any increase, but there's going to be increases. Would you rather see the deductible go up, the co-pay go up?
What's your
What
pleasure?
What areas would you prefer to see
changes probably in all of
increases in or changes?
Where the city go bankrupt and you lose all health insurance.
Yeah,
There's gotta be a
I mean, that's
stick.
the option. I mean, ultimately, that is the option.
Yeah,
Well, I think we talked about it, I'm sorry, Mr. Chair.
sure.
We talked about it last week. Our problem is that we've got expenditure restraint from the state.
Yeah.
They keep us capped on what we can spend. Even if we bring in more revenue, we can't spend any more than that. So there's no way we can even get this back, put this, to taxpayers to help pay for it.
Right.
Not saying that it's something we'd want to do, but, we don't even have that option if we wanted to.
Well, I think
That's
that's,
my point.
I think that's a fair point too, because if the goal is to keep the plan design the same, we can't shift that premium. The city pays too high a share of premium. There would have to be other, I don't want to speak for Peggy, but there'd have to be
Service
other
cuts,
cuts. and-
major service cuts.
elsewhere. So we really are stuck between a rock and a hard place from a budget standpoint, where we do have to use both avenues available to us.
Alderman Stefanski.
So I have two questions. When is the decision that we have to make about this need to be done by?
Next Tuesday.
The 17th.
The sooner the better.
Of this month?
Well, open enrollment is next month. I mean, we certainly could look at the beginning of January, but then you're cutting it really, really close.
Wow. I guess that throws my idea out then. I was gonna suggest how hard is it to get employees that say, everybody at Public Works, we're having a meeting, there's nobody doing nothing for a half an hour, an hour. We have a meeting.
Well, it'd be an hour to
City Hall.
explain to them.
Right, everybody at City Hall, boom, you're coming into a meeting, that's it.
Yeah, and it's what Rebecca said, that, well, the input will be, keep it the same. And I don't care about retirees if you're an active person, and if you're a retiree, then it's, well, let everyone else pay for it. You put groups against each other.
But you can't do that, you've gotta go in with the saying that, okay, the insurance cost is gonna change. Here, it's gonna go up, here's the options of how it can go up for you. Not, it doesn't say the same, that's not an option. That's what I was kinda getting at.
Well, I guess the other part of that too is, this isn't negotiable under Act 10. We can and must dictate it.
But we can seek input.
We can seek input.
And we should.
Right.
I think this is a perfect example of where we hire experts, I know you guys are on the committee and you had meetings and a lot more in-depth discussions on this. And some of us have been on this committee longer and have more general knowledge of it. But for any of us or all of us to become experts on the intricacies of healthcare financing, we hire professionals to give us their guidance. They're giving us options. We're gonna have to pick some or all of them, unfortunately. But it's just not something that we can all become experts on.
Right, we don't know what those costs
Just like
look
traffic engineering.
Right.
I can't be an expert on traffic
Yeah.
engineering. I can certainly do what the
We don't know
sensible
the
thing
cost
is.
curves, we don't know what
Yeah.
the trends are, we don't
Yeah.
know what the.
Yeah.
Well, and that's another great point, because the solutions we talked about tonight were not all inclusive of everything we looked at. There were a lot of other options, and we believe that, again, the goal is to still offer a very competitive health plan and keep costs as low as possible. So we felt that the mix that we brought forward is the best of each scenario, so,
Because you understand that we still have to hire people.
and keep
Okay?
people.
We have to treat our current employees fair, and we have to treat our retirees fairly.
Correct.
You know?
Mr. Chair, can I ask another question? How do our deductibles affect our premiums?
The higher they go, the lower the premiums you go.
But what's the ratio? I mean, so, I guess it's, let's say we went 500, 1,000 on the deductible. What does that do to the premium?
If you went 5,000, 1,000, it would, well, I don't have a direct premium outlier, but it would the premium from,
An additional 156,000 we'd get back.
Thank
From
you.
the 257.50.
Yeah.
So going to 257.50 from 100, 300, we're at 195. We would get an additional 156,000 if we went from 500 to 1,000, from 257.50
So-
to 500,
a
1,000.
total savings of 351,000.
Oh. And that would bring us more in line with the statewide average. Or we call it an average or a median? Doesn't matter.
Median's a type of average.
Median, yeah.
But then things like, the concern with the non-emergency versus emergency room being covered. Remember that one we talked about
Yeah.
for quite some time?
Yeah.
One thing too, I'm thinking people are explaining, hey, you need to start thinking about how you're doing your care.
Yeah.
Instead of just going to an emergency room, well, maybe now I need to go to urgent care, or can it wait until tomorrow when my doctor's available?
Yeah.
That's the kind of mentality you're talking about, you gotta get people to
behavior change.
look at.
Well, my concern right now is you go to the emergency room and you have what you believe is a real emergency.
Correct.
And then the plan says, nah, that part bothers me, that's the
That's me
80,
too.
that's the
Yeah, me too.
80,440.
I would tell you in the grand scheme of things, if that's the one that we don't like, and it's only $80,000 in savings, I think that would probably all be one that we could take off the list, but we have to be careful, because if that's the first one to go, then there's gonna be something else that someone's not, we do need the savings.
Do we have a maximum out of pocket?
Yes, it
What is
is total, I think it's 4,800 single, 9,600 family, don't quote me on that, I think that's about right. The odds today of anybody hitting that are astronomical, because once I hit my deductible, all I'm responsible for is copays. So my prescription drug copays and office visits and things like that, and that's an extraordinary amount of copays I would need to hit $4,800 worth of liability.
The premiums don't count towards that.
No, premiums
It's
don't count
just
towards-
plan design
that's just
costs.
plan costs.
Okay. Yeah, we've talked about this for a little while. We have some, yes.
Just one thing about the whole non-emergency emergency. This is a place where a lot of misuse of the plan is happening. Maybe one suggestion would be to change the emergency room co-pay from 250 to something higher, if you're gonna get rid of that. Because we still have to drive,
Drive a
Change
behavioral
behavior.
change.
and so like a 500 might not be earth-shattering to somebody, where 6,000, like your example, would have been. But this is an important plan change for us as far as driving behavior.
All right, and usually we don't have opportunity for public comment at these meetings, but we have some important active employees and retirees here who have been trying to get recognized. Just real quickly, if you want to say something to the committee, I do want to give you a chance. Please, go ahead, whoever wants to go first. And tell us who you are.
Can we get names? Yeah.
Yeah, just quick, my name is Jesse Schwartz. I'm with the West Dallas Fire Department. I'm also the Vice President of Local 1004. So here just as a representative, trying to get an understanding of where things are going so we can keep our members informed of what the direction it is. I certainly appreciate that it's a tough spot for the city to be at. These are some pretty significant numbers that we're looking at. I can also appreciate the creative means that you're looking at, trying to come up with ways to curb behavior versus just changing costs. I think that's a good long-term change, and hopefully some of these things align with that and show us some pretty decent cost savings in the long run. The biggest concern that I have looking at this is one thing I just want to understand. So the approximate $1 million savings that we're looking at here, that is no part of that is tied to the premium increases on the top, correct?
Correct.
That's just plan design changes. The premium increases is just proposed increases to bring us in line with comparables, or just proposed increases in general?
It's just cost. So I will say, while the $1 million savings has no impact on the premium, it also does have an impact on the premium, if that makes any sense, because without these plan design changes, the premiums would have to reflect the $1 million savings. Does that make sense?
Sure, so you're saying the proposed 7 and 11% are attainable because of the $1 million savings
Correct.
that you're looking at. And again, it's been brought up a couple times. The biggest concern that I have, again, is that increase to the retirees. I understand and can appreciate that they're one of the biggest drawers on this fund. At the same point, being a firefighter, we have a couple of retirees in the room here. We have the option to retire younger. Again, as some have stated, because of the nature of our work, retiring at the traditional 65 just isn't safe for a lot of members in that role. There's a few administrative positions that people can move into that's not quite as tiring on the body, but those are limited, and that isn't there for everybody. And then along with that, obviously the sacrifice that these members have made through the fire department, through the police department, to the city, and the service that they've provided throughout their career. I certainly myself, self-serving, but I feel that we do owe it to them not to completely neglect them once they move into retirement, and not offer them some sort of safety net that all of a sudden you retire, these costs become astronomical, they can no longer afford that for themselves or their families, and now have to get some astronomical catastrophic insurance, especially when we have a up to 3% higher rate of cancer. Most of our individuals, rates of PTSD, suicide is increasing throughout all of the fire service and the police service. And there's a lot of risk that's associated with the career that we're going into. And especially for that 11% increase in retirees, they eat all of that cost. You know, on the actives, I certainly can understand we pay a percentage of that increase. So of that 7% increase, I'm going to say a very small amount. So somebody who's retired, they're paying the entire 11% increase. And that's a huge hit for somebody that's on relatively a fixed income at that point. So as you continue to look at this, again, I understand that we need to make changes and we need to try to find cost savings, curb some use, or whatever we need to do, but I think we really need to look at the impact that we're having on the retirees when we're looking at changes that are that significant. So that's all I'd say. I appreciate the time to say a piece, and again, I understand this is a very complex situation, and I can appreciate a lot of the creative ways that you guys are looking at coming up with cost savings. Obviously, that something needs to happen, and we know something needs to happen. We're not saying that I expect everything to stay the same and keep trucking along. That's impossible, and we understand that. I think a lot of members would be more in favor of changing things like deductibles, changing things like copay, increasing those instead of paying an additional 11% per month on premium shares. And you don't have a change in your insurance.
Okay,
Thank you.
thank you. All right, anything else on that issue before we move on to our next agenda item?
Anyone else want to talk?
Tell us who you are, Gary Stryker.
I'm retired from the fire department, Gary Stryker. If I understand this right, the 11% would be on the cap rate that we went out at? So, okay. Because mine went up almost $200 a month last year. It'd be over $200 a month this year. Is this going to continue? Because that number of how many we're at 800 now, it'll be hundreds of employees in a short period of time if this keeps going. I mean, there were, what, maybe a handful, 6, 7? There will literally be hundreds in 2 or 3 years if these 11% increases keep going.
Okay, thank you. All right,
Mr. Chair, can I?
Alderman May.
To that point, you're right, because we implemented that just a couple of years ago, so we're only seeing,
That's been in place for many, many, many years.
how much is
The
it?
increases haven't been that large.
The weighted difference.
The idea, though, is the wave, though, for that 10-year period, it will get to a point, I would believe, that you will hit more people.
Yeah, we will be.
So there's kind of shelves. So back in 2016, when our premiums lowered, then it was kind of like a resetting of everything. But up until then, some of the highest payers are some of the older ones, but those are usually ones with different plan benefits.
So the people who left in that 1 year may be the ones really truly experiencing that hit.
And 16, when the rates were lower, because now they've only continued to go up. But if we would change something like maybe a high deductible plan next year, then that could all be reset again.
Mm-hmm.
Okay.
I see what you're saying.
All right. Well, thanks, everybody. Then let's move on to item 4 of our agenda. And the item is considering compensation and performance evaluation data of city officials and deputy assistant service employees For agenda item 4, the committee may convene in closed session pursuant to the provisions of section 19.851C of the state statutes for the purpose of considering employment, promotion, compensation, or performance evaluation data of any public employee over which the governmental body has jurisdiction or exercises responsibility. This committee may reconvene in open session after completion of the closed session to consider the balance of the agenda.
Move we go into closed session.
We have a motion. Is there a second?
Second.
We have a motion and a second.